Dr. Mokhtar from Egypt is going to be moderating the next session on neglected fractures, mangled fractures. Dr. Mokhtar, please join us.
Okay, thank you all.
Hello, everyone.
Hello.
My name is Ahmed Kholeif. I'm a professor of orthopedics in Cairo University. And Dr. Mokhtar is going to start now. Dr. Mokhtar, he's a professor of orthopedics in Ain Shams University. We have also Professor Amr Farouk, assistant professor of orthopedics in Ain Shams University. And our colleague, Professor Ossama Elshazly, is also professor of orthopedics in Ain Shams University. These are all groups, we work all together in the Greater Cairo. I work in Cairo University and all my colleagues work in Ain Shams University. Cairo is a huge city with more than 20 million inhabitants. And if you come to Cairo, you find very good traffic. So really, you will have a very chance if you are an orthopedic surgeon to see all the different modalities of trauma you have. And with the big amount of accidents, we have also big amounts of surgeries being done. We have more than 8,000 orthopedic surgeons. Not all of them are foot and ankle surgeons. So sometimes, which is good enough, that someone is doing operations which are not the optimum or the practical, which gives extra load for the foot and ankle surgeons to do not only the primary ones, but the revision ones. So we have got here a bunch of the three of the most experienced orthopedic surgeons, foot and ankle orthopedic surgeons in Egypt. And I'm happy to start with this session about the mismanaged ankle fractures and how to diagnose and proceed with them. It's going to be an interactive discussion with discussion. All of them are clinical cases, and we're going to get lessons learned out of them. So let's start with my dear friend, Professor Amr Farouk. Professor Amr?
Yes, Dr. Kholeif, thank you. First of all, I would like to thank for this great invitation and for this nice day. Do you hear me? It's okay like now? Okay, let's
we can hear
start
you, yes.
with this. Okay, thank you again. And let me start with this case presentation. This is a case of mismanaged ankle fractures, and let us try to discuss what was mismanaged and how can we get it better. This is a male, 34 years old. All of us see the slide. The audience sees the slide, huh?
You need to. Okay.
Yes, it's already, yes. A 34 years old male, which was presented to me like this after having had this operation about 1 week ago, just 1 week ago. And to some reason, the operation ended like this. It's clear that he has a motor car accident, trauma about 1 week ago, and then he was operated upon by one of our surgeons, our colleagues, and it ended like this. Would you like Dr. Ossama to comment on this X-ray?
Dr. Ossama, open the microphone.
Unmute.
You need to unmute yourself, Dr. Ossama.
Dr. Mokhtar.
You need to open the mic.
Dr. Ossama, please unmute.
Dr. Ossama, you need to unmute the mic.
Can you hear us?
We can't hear you, Dr. Ossama.
Okay.
Dr. Ossama, can you hear us?
Dr. Mokhtar, you can comment until Dr. Ossama.
Let me carry on with you. Let me start with you. Dr. Amr, I can see from this X-ray, if you start from top to down and from anteposterior to lateral, first, the fixation does not seem to be very adequate. One screw, which is in the interfragmentary, seems to be in the fracture side. There's definitely shortening of the fibula. The plate needs to go a bit down. The fibula is short. Syndesmosis is open, and there is a Tilo-Chapeau fragment which is seen being displaced, and the talus is actually moving laterally towards the fibula with widening of the tibial clear space. In the lateral view, I can see the plate is on the top part, is on the lateral side of the fibula, but I don't see where it is going on the down. It seems to be the whole fibula distal part has moved forwards. So this is another thing which, of course, takes the talus with it, causing this rotational malalignment. There is definitely some missed fragment or loose fragment on the anterior part of the ankle. I think some of it belongs to the Tilo-Chapeau fragment. So I think lots of work needs to be done for this, Dr. Amr. Dr. Ossama, are you with us? Can you?
Yeah, I'm with you. Do you hear me? Do you hear me
speak?
now?
Yes.
Yes. Welcome, Dr.
Yes, we can
Yeah.
now.
Okay, I'm sorry for this technical problem. I think it's supination external rotation injury with medial malleolar fracture, and we have also high fibular fracture, Weber type C, and syndesmotic injury. And I see here there's anterior impaction and fragmentation in the anterior part of the distal tibial plafond. So it's not an easy case to be treated like that. I think. Yeah, it should be reduced, fixed, syndesmosis should be fixed, the restoration of length of the fibula, medial clear space is still wide, syndesmosis is wide, and it seems not reduced. Also, the anterior impaction is not regained and not fixed properly.
Fine. Thank you, Dr. Kholeif. Thank you, Dr. Ossama. I think there is a lot of, maybe a lot of wrong things in this operation, a lot of things to be corrected. So that's why I tried to go back to the original or to the old x-rays at the time of trauma itself, before this operation. And this is what I could get, that there was an ankle fracture like this, Weber type C, as Dr. Ossama said. But unfortunately, in the CT scan, in these cuts, it's clear through the sagittal cuts that there is anterior dislocation of the ankle. So it was not an easy case. The ankle was completely dislocated. And the axial cuts show the anterior fragmentation, which Dr. Ossama was talking about. So this anterior fragmentation of the distal tibia led all the ankle to go forwards and to dislocate like this. Again, the three-dimensional CT, which I like in such cases, to be able to see all the fragments. It shows that there is a lot of fragments, a large chapeau fragment, anterior fragment at the tibia, a medial malleolar fragment, which is not a traditional fracture of the medial malleus. It's much more fragmented like this. And of course, the ankle is was subluxed or was dislocated anteriorly. So another problem is this. This is how the skin condition was when this patient presented to me. This was after the operation done. It seems that there was a problem in closing the skin. The patient was very edematous and ankle was very swollen. So the previous surgeon had to do this type of like tattooing in the skin to be able to close the skin. The patient had a lateral incision and another direct anterior incision, or at least that what was clear to me after examining the patient clinically. Dr. Mokhtar, do you like to comment?
Yes, it's a difficult case, Dr. Amr, and I think the cause of malreduction maybe the surgeon didn't target the anterior dislocation of the syndesmosis, so he couldn't reduce the fibula, maybe. And the skin is tight, as you see, as we can see in these photos. Do you have a CT of the position, post-operative position, Dr. Amr?
Yes, I will go through the rest of the X-rays, but this is back to what the surgeon did. I find that the surgeon did a very good thing, that he could reduce the talus back to the mortise. I think this is not bad. He could reduce the dislocation like this, and this is at least one good step that he could achieve. But it seems that he tried to put a positional syndesmotic screw, but he couldn't reduce the syndesmosis in a proper way. So,
Dr. Amr, a note here. Do you have an explanation of the anterior approach the first surgeon used?
I think, as Dr. Ossama said, maybe the first surgeon has seen that there is a lot of fragmentation anterior, or maybe a large chapeau fragment anterior. So he decided to attack this fragment through a direct anterior approach. But the surgery ended like this before even fixing the anterior fragment. Maybe because the ankle was dislocated anteriorly, so he was trying to reduce the ankle from anterior, the talus from anterior to posterior. That's why he added an additional anterior approach to the lateral approach. But he
And do you,
didn't. Sorry.
and do you have explanation why he didn't fix the medial
I think he tried to go for
the medial malleus? Why it's not fixed?
I don't have an explanation why the surgery finished before fixing the medial malleus. Maybe he couldn't fix it. The surgery took a very long time that he accepted the position like this at the end. Even the reduction of the fibula itself in the lateral view seems malreduced. So
yes, this is
I
what I
started
think
to.
is the main thing. Tilo chapeau fragment. I think he tried to reduce the Tilo chapeau fragment, but he could not, because I think this is the one which prevents him from putting the syndesmosis in the proper way. Maybe he tried to see the syndesmosis or to open it, but he could not reduce it because he put the plate of the fibula first. And as you said, that the plate of the fibula is put so that the fibula, the distal part, is anterior. You can never get the syndesmosis back with the fibula in this position.
I think we don't need to find explanations for these lots of pitfall. It seems that the surgeon is not experienced with such kinds of trauma. So there are lots of pitfalls. We don't need to find explanation for him because it seems very,
Yes.
it went wrongfully. Yeah.
I tried to do new CT scan for the patient after the fixation to be sure of the current position. It seems that the syndesmosis is opened, it's malreduced, and maybe everything is malreduced. Dr. Mokhtar was asking about the CT after the fixation, and I think these are some of the important cuts of the CT after the fixation. It's clear through the coronal cuts that the syndesmosis is opened. The medial malleolar fracture is not fixed. In the three-dimensional CT, it's clear that even the fibula is malreduced, like this. So, Dr. Ossama, may I ask you, please, what do you think the sequence of revision or the sequence of fixation in such a case? what should I start with, and what is after, and what is after?
Yeah, it's a really difficult case. But I have tendency to start laterally with the fibula to restore the length of the fibula first, and put a plate. Then I will try after that fixing the medial malleolus through a separate approach. I can, through the lateral incision, try to find and reduce the telochapeau fragment, and after fixation of fibula, and reduce the syndesmosis, then I fix the syndesmosis. I think this is a sequence which I will go through.
Fine. Dr. Kholeif, do you think there is
But you have
a
got already
different...
an anterior approach there.
I will leave this anterior approach. I will go just
Yes,
through
I
the
think the
lateral
anterior
approach,
approach,
and then I will make through this
you
lateral
leave it
approach.
closed.
Yeah,
You will
yeah.
not
I will
open.
leave it closed. I will not open again because I think it's dangerous. You need to go through the lateral approach and then fix fibula, restore the length, reduce telochapeau fragments through the lateral approach, and reduce the syndesmosis after fixation of the medial malleolus.
So the syndesmosis is the last thing. Dr. Kholeif, you agree that the syndesmosis will be the last thing to be corrected or to be fixed?
Well,
Or
I will
you
go the
prefer
other
to
way
do...
around. I think the syndesmosis needs to be explored and open. I prefer to do the syndesmosis first, because having the fibula back in place will put everything in order, and would make the reduction of the medial malleolus even easier. Because once you just put the mortise in position and put the close the syndesmosis, then the deltoid ligament with the attachment to the talus will be easy to manipulate, so you can easily pull on the medial malleolus and put it back in place. So I would start with making sure that all the lateral structures, the syndesmosis is perfectly reduced, fibular length is done, and only then I go to the medial side.
Fine. So is that your routine
That's my personal
sequence?
approach.
This is your routine sequence of fixation, Dr. Kholeif. You do the lateral malleolus, then the syndesmosis, and then the medial malleolus in all POTS fractures.
In most of my POTS fractures, sometimes I open the medial malleolus first, explore it, and make sure that everything's free. Go to the fibula, get it done, and then come back to the medial malleolus. But I usually
Okay,
fix the lateral malleolus first.
Okay, that's why I have put these two choices. It seems that Dr. Ossama has chosen choice number A, which is lateral, then medial, then syndesmosis, and Dr. Kholeif prefers to choose choice B, which is lateral, then syndesmosis, then medial. Okay. The problem, Dr. Ossama, is that we already have two approaches. So when I tried to start, I started by the lateral approach, which is the same old approach of the old surgeon. I opened it once more, and I removed the old plate, of course, and tried to reduce the lateral malleolus as a start. The other approach I wanted to use is some sort of anteromedial approach to reach the medial malleolus, and at the same time to be able to see the anterior fragmentation of the tibia. But unfortunately, I think it was difficult to do this anteromedial approach in the presence of the direct anterior approach, because the skin island in between would be very, very, very small. So I tried to go once more through the same anterior approach, which was difficult, but I have increased the approach proximally to be able to reach anterior and medial at the same time through this approach.
That looks
Okay,
okay. I mean, to me, I think it's a hard work for you.
Fine. Okay, this is my intraoperative C-arm photos, image photos. I used a very long distal fibular locked plate like this, and I think it could reduce the fibula, as you see in the anteroposterior and in the oblique view like this. The problem was in the tibia, the large chapeau fragment could be fixed with a separate screw like this, but the fracture of the medial malleus was rather a coronal fracture rather than the usual fracture of the medial malleus. So that I couldn't fix it except with like an anteroposterior screw through the medial malleus. So I used 3 screws like this to fix the anterior fragmentation and even the anterior fragmentation of the medial malleus. And I used 1 long syndesmotic screw like this, traversing the 4 cortices to be able to reduce it like this. And
Very
this
nice.
is
So what was your sequence of reductions then, Dr. Am?
like you said, Dr. Ahmed, I started with the lateral malleus, then the syndesmosis, and lastly the medial malleus and the chapeau fragment. Maybe the chapeau fragment before the syndesmosis, the chapeau fragment before the syndesmosis, and the medial malleus like this at the end.
Yeah,
It seems okay.
did you
Did you
open
do
a separate
lengthening of the
incision
fibula?
medially? You did open a separate incision medially for the medial malleus, like here.
Yes,
Or
a separate incision medially. Yes.
okay, it's very nice.
But I had an intraoperative problem. I want to take your opinion about it. I always felt at the end of the operation that the talus is still a little bit anteriorly translated in relation to the distal tibia. I tried to do a lot of dorsiflexion of the talus to be sure that it is well reduced, but this was at the end of the operation. I still feel that there is some sort of a little bit anterior translation of the talus in relation to the distal tibia, but I couldn't reduce it more than this. I think it's okay.
Okay.
I think
Yes.
it's absolutely fine. I can't do any better than this, to be honest. Well done, Dr. Am. Thank you very much.
This is 3 months after the operation follow-up, and I think the position is still okay. So at the end, we need to do proper preoperative imaging for all our ankle fractures, including X-rays and CT. We need to do good planning for the position and the approach of the patient. And I think always the best trial for the surgeon and for the patient is always the first trial. So we always need to do it correct from the first time. Thank you.
Yeah.
You are absolutely right, but this present only in heaven, in the good world. But with okay, thank you very much. That's a very interesting case. Next, we go with Professor Mokhtar. Are you ready for your presentation,
Yes,
Dr.
you
Mokhtar?
can hear me, yes?
Okay.
Should I take, is this next case my case or Dr. Osama's case?
I think
This is Dr. Osama's case. I know this is.
Okay, so you
So
can
this is
start,
Dr.
Dr.
Osama.
Osama.
Would you like to take over, Dr. Osama, now? Okay.
Well, okay. Thank you, Dr.
Take
Ahmed, and
control.
thanks Amr Farouk after his presentation of case. And as Dr. Ahmed said, we may have lots of complications from young or junior surgeons who may do some complications, and patients got referred to us to do correction. So I will go with these cases of neglected pilum fracture, and let's start with this 42 years old lady. She had motor car. She had falling downstairs, and she got this fracture here. As you see here, we have a pilum fracture with lateral malleolar fracture, with medial malleus fracture, and with axial loading causing anterior process fracture. So do you want in such kind of fractures, do you know further investigation? Dr. Amr Farouk?
Yes, I think we need a CT scan
Yes.
CT scan.
this
Yeah,
case.
here is a CT
Yes.
scan showing here a fracture of the distal tibia type C, and we have comminution anteriorly, and we have fracture of the fibula as well as fracture of the medial malleus. So treatment options for such case. I would give you some options, and I wish our participants can respond in the presenter in the chat in the questions and answer. If you can replay for these options, who will go for reef, fibular plating, anterolateral tibia plate, medial malleolar fixation? Who will go for external fixation for such case? Who will go for primary arthrodesis of this case? Because these are the three options which can be used in such comminuted pilum fractures. So any one of the attendees, could you answer in the chat box of questions and answers? We have 11 attendees now. No answers. Okay.
Okay.
Well, our participants, our faculty. So, what do you choose, Mohamed Mokhtar, for such case? Mokhtar. Yeah, we got one response here. It's one. Okay, 1B. Okay.
Yeah.
We had one answer. We had another one, B. Okay. Thank you, Jackie. So fixation of such cases is
My response is to go for this. Just I need to know the soft tissue condition. This is going
Soft
to dictate
Yes.
my
condition.
condition.
Yeah,
Yes.
that's good. It's adequate. There is swelling, which is mild to moderate at that time. Nothing is contraindication for open reduction internal fixation.
Then I will go for it because external
Fixation.
fixator will be followed by internal fixation. So
Yeah.
the soft
Actually,
tissue structure, I
our
will go.
junior surgeon in one of the remote hospitals dealt with the fracture in that way. What's your comment, Dr. Amr Farouk?
I think there is a problem in reduction of the fibula. He just of the tibia. He just reduced the medial malleus, but he neglected or couldn't fix the anterior fragment, and there is still subluxation or dislocation of the ankle anteriorly in the lateral view.
Yeah.
And after that, he even fixed the syndesmosis, and I think he over tightened the syndesmosis while the talus is not inside the mortise. The talus was anterior, and he tried to fix the syndesmosis. I think this is over tightening because there is no talus inside.
Yeah, I agree. I think our surgeon dealt with such case as a malleolar fracture, not as pilum fracture. He neglected to reduce the anterior articular surface at all, and he fixed the malleoli here. He put the syndesmosis in this bad way, and for that, the patient, after a while, around 4 months, start to develop this appearance: anterior subluxation, malunited distal tibia, and the syndesmotic screw here of the patient even was not in the correct position in the CT scan. Look, it's
That's
posterior
what I
to
was
the tibia.
saying. I think it looks going back
Yeah.
in the lateral
So
view.
this is the situation right now. The patient has mal-reduced distal tibial plafond and medial malleolar fracture with mal-reduced syndesmosis in this way. So what should we do for such case? Further management. Here, arthrodesis, or now we are 4 months. And this is a
4
CT
months
scan.
down the line.
Yeah.
How old is the patient? You said
The patient is
younger.
42. She's lady.
Quite
She's
young.
young.
Quite young.
Should we
yeah.
try joint preservation for such
I
case?
think we can give her a go. I think we might give her a go because she's
We
still
can.
the bone quality is not that bad. Number one. Number two, soft tissue condition, according to what you said, is not that disturbed. There is no infection or anything like that. She's not a
Yeah.
smoker or diabetic. So I think it's worth it to give her a go before going for arthrodesis. Arthrodesis is always there
This is soft
whenever we
tissue
need it.
condition of the patient, and this is the CT scan. So you go for joint preservation. Actually, in literature, I couldn't find papers except one paper recently published about neglected pilon fractures more than 6 weeks treated with joint preservation. Most of papers was treated with arthrodesis. So the patient actually, she went to most of foot and ankle surgeons and arthrodesis was recommended. I told her that we can have a possibility of making a joint preservation, but I'm not sure about the outcome, but we can reduce and we can return it back to reduced position. And my plan was to do a double approach to remove these malreduced syndesmosis and then to make anterolateral medial approach to reduce the medial malleolus and the anterior bony fragment, and to make osteotomy anteriorly. Then I will make open wedge and put grafting here to return the mortise to its position, and then fixation with plate fixation. And this is my technique. As you see here, this is the joint. The joint was nice. It was not bad. The talar articular cartilage was not bad at all. I did landmark for this osteotomy place, and then I did this kind of opening wedge osteotomy with this distractor. After opening the osteotomy, I put the graft inside, and then I put this graft, and then I fix it with plate. And here is the mobility of the ankle inside the mortise, and here is the imaging of the case. Look at the distal articular surface. It's not bad, reduced, and here is the position of the articular surface. And here is the follow-up of the patient with the ankle is reduced. And the patient was really happy with the range of motion she got. Of course, there is limitation of plantar flexion, but she had good and nice range of motion and good alignment. Even if she complains later of ankle pain, we can do a fusion or arthroplasty or whatever without a problem. I will show you another case of 35 years old. This is courtesy from my friend Daniel from Kenya, and he fell from height in remote village, and he was presented 6 weeks after trauma, and CT scan was not available for this patient. But look at the injury. This is 6 weeks after trauma. It's neglected, untreated, with too much comminution anteriorly, and as you see here, it's comminuted pilon fracture. So further management for this case, Mohamed Mokhtar, what do you think? To go for arthrodesis or to go for joint reconstruction and the preservation? Mokhtar? Mokhtar, do you hear me? Okay, Amr Farouk.
It's a very difficult case, Dr. Ossama. If it is presented 6 weeks after trauma, I think we will need to do CT scan, and then to try to decide whether to go to arthrodesis or joint preservation. If the CT scan is not available, I think he is a young patient, and as Dr. Kholeif said, we don't have to rush for the arthrodesis from the start. We can take a chance to reduce the ankle like the previous case, and try to fix it by joint preservation. If the joint preservation failed, then I can do later on arthrodesis.
Yeah, this is actually what we had done. Here is the anterior approach, and we could fix it through this anterior approach. We return back the anterior part of the tibia and we put the graft. Then we put this long plate inside, and here is the restoration of the joint line with fixation combining osteotomy and bone grafting. So this is the follow-up of the patient. The final case I will show is another case with another scenario of pilum fracture. He is 70 years old male patient with antidepressant treatment, otherwise medically free. He had trauma to the ankle with intact soft tissue, and he got this kind of injury. Actually, this is a CT scan showing lateral malleolus, distal tibial fractures, which is pilum fracture. 3 columns are broken, type C. And the patient management here, what do you recommend for this? To do open reduction internal fixation, or Elizarov, or primary arthrodesis, or conservative? Beware that the patient is 70 years old. He is on antidepressant treatment, but he is medically free. So participants, do you think I would like to receive from Jacqueline Valero or any of the participants, what's your choice? He is 70 years old. What do you recommend? Kholeif, what do you recommend for such case?
Well, this is a very comminuted injury, and the anterior part is very much affected. Again, the soft tissue condition will affect, but I have also 70 years old male patient, so I'm not expecting very good soft tissue condition anyway. So I would really be very cautious with this. So if the patient is healthy and the distal circulation is okay, so I need to check this first: the circulation, comorbidities like diabetes or other or peripheral vascular disorders or ischemia. If the patient does not have any of these, then I would go for internal fixation. Otherwise, I would go for external fixator with minimally invasive. So I might fix the fibula and then do distraction by a fixator until the condition of the soft tissue gets better. But
do you think in primary
if I can get everything back to
do you think that
it is an option? To be honest, I think it is an option. Definitely, in a 70-year-old male patient, I think it is an option to be considered.
Yeah. Amr Farouk?
About I want to know the level of the activity of the patient before having this fracture.
The patient is a retired lawyer. He has a grandson. He goes around. Yeah.
If he is completely no comorbidities at all, no diabetes,
antidepressant treatment.
Antidepressant treatment is not contraindication to try to do open reduction internal fixation for the patient. I think we can.
What was done by the surgeon? He put fibula, he restored the lens here. He tried as much as he can to put anterolateral plate to restore the articular surface, and he put here medial malleolar plate. But the patient here is senile, 70 years. We have to expect osteoporosis. We have to expect with antidepressant treatment that he may be compliant for non-with pairing in this case. So what happened for this patient is broadening the plate later on, broadening here, and walking, and he came to me. Here I decided to make for this patient, after mechanical failure, to remove the plates here and to make some sort of debridement, because I take a swab because I found like a low-grade infection, and after debridement I put some bone cure, because there is complete loss of the anterior cortex. When we made debridement, the anterior cortex was completely destroyed. So we gave him this first stage, and then we made for him a second stage with fusion and reconstruction of anterior cortex using large cortical graft and we put it here, and then we fix it using a plate and nail. And here is the follow-up of the patient when he was fused with again, and here is his work again, and this was nice for this patient and more rigid. What we should think about is arthro patients who have fragility fractures and elderly patients with comminution of pilum fracture. We have to think in tibiotalo-calcaneal nailing, which shows a good results in the short-term outcome, and there is a trending for making primary arthrodesis for fragility fracture. These are the three cases. So if anyone have comments, take home message: neglected pilum fractures due to mismanagement or delayed management due to lack of medical service may be encountered in some countries. Arthrodesis is a gold standard procedure, but joint preservation can be chosen for young active patients if there is adequate articular cartilage, but elderly patients with fragility, pilum fractures, and comorbidities must be treated with primary arthrodesis. So thank you very much. I think until our
Very good,
friend,
very good, Dr. Ossama.
yeah, we can have some questions from the attendees if you like. Dr. Amgad Halim
I
is saying,
wish you can go for the,
yeah, Dr. Amgad Halim, thank you, Dr. Amgad Halim, for your greetings.
Thank you, Dr. Amgad.
So any questions from
thank
the
you, Dr. Amgad,
participants?
thank you.
May I ask Dr.
I wish you
Ossama?
can go
in-
again.
Yeah.
Dr. Ossama,
Yes.
in the two-stage, in the last case of two-stage operation, what was the time between the debridement and the next step of
Around 6 weeks. 6 weeks. I waited around 6 weeks. The patient received antibiotics, and we were making follow-up with CRP and ESR. And once they are normal, we made his arthritis. So I think Mohamed Mokhtar had came back.
is back? Yes.
Yeah.
Yeah.
Sorry
Can
for
go,
this
Dr.
absence.
Welcome
You
back.
can take
Now.
control.
Thank you. Take control. And then
Seems
next.
the internet connection, Dr. Mokhtar. Carry on, carry on.
Okay, can you hear me now?
Yeah.
Yes,
yeah,
yes, Dr.
We can hear you now.
Okay, I'd like to thank my friend Selene Parekh for his great effort in managing this course, and I'd like to thank all my Egyptian friends, Dr. Ahmed Kholeif, the current president of the Egyptian Foot and Ankle Society, Dr. Ossama Elshazly, my dear friend, who is the secretary of the Egyptian Society, and my dear friend Amr Farouk. I will show you this case. This patient is a 37 years old male who had this closed injury. As you can see, it's a high fibular fracture, which is definitely associated with a deltoid injury because the medial clear space is very wide. And you can see that the fibula is short here because of the comminution. And there is a significant ulnar shift and tilt in this case. May I ask, my dear friends, if this is your case, what would you do how would you plan the treatment in this case?
For me, I think, Dr. Mohammed, the most important issue is restoration of fibular length, number one, because it's the most challenging part. It's comminuted, so I will try to reduce it, fix it, and with good restoration of length. Second, I will check syndesmosis because this is sweeper type C with high incidence of syndesmotic injury. And after I fix it, I will check for deltoid ligament and medial clear space with gravity test. If there is affection of the medial clear space, then I will repair the medial ligament.
Yes, I totally agree with Dr.
May I add
Ossama on your
something?
plan.
I think,
Yes, Dr.
Dr. Mokhtar, I have another something I'm worried about is the line of the distal articular surface of the tibia, because I think the talus is going a bit higher up. So I would go for a CT scan. I think there might be a depressed fragment in the lateral part of the tibial plafond. So I really would like to check this because the talus is moving a bit higher up.
I think CT is always necessary when you are in doubt, but maybe because the fibula is going up, it's pulling the talus with it in that case. I agree that this is the sequence of operative treatment, and I would have very low threshold to repair the deltoid ligament in this case. The patient underwent open reduction and internal fixation, followed by removal of syndesmotic screws 3 months later. And here you can see the X-ray after 3 months of the operation. He fixed the fibula with synthetic graft. He put 2 syndesmotic screws and removed 3 months later. And this is the patient later on. May I ask my dear friends, what's your comment about this case, about this X-ray?
Yeah, I see the
Dr.
fibula is not. I
Yes,
see
go
the
on,
fibula.
Dr. Ossama?
There is shortening present inside the fibula, and I think the syndesmosis is not even reduced.
Yes, and there is no X-rays when the screws were in. So the syndesmosis, I think it's the same X-ray of the preoperative with this bone graft and a plate. The ankle is the same in the post-operative and the preoperative X-ray. Fibula is still short, but there is a huge synthetic bone graft, and you need. Aywa?
I think there was a fragment of the fibula in the first X-ray. I think the surgeon removed this fragment and put the ends of the fibula against each others, and he thought that this synthetic bone graft would achieve union, but I don't think the surgeon could restore the length of the fibula even while the syndesmotic screws were inside. The fibula has never reached its original length.
Yes, I agree. He wanted a good union with end to end, but he didn't think about fibular shortening and its effect on the ankle. And as we all know that this talar translation decreases the contact stresses in the ankle and leads to early degenerative changes. So now we are facing a new situation. What is your opinion now after this first stage? Dr. Ahmed, Dr. Ahmed?
I think if I can say yes. I think we need to take this plate out. We need to have fibular length restored. So I think we need to have like some form of distraction through the fracture site, and we might need a bone graft, or even without bone graft, just fibular distraction to restore the length. Then I need to open the syndesmosis, explore it, and put the fibula back to its place and fix it, and then go to the medial side, explore the deltoid ligament and the medial space. I'm expecting to have some soft tissue inside this area, so it needs to be cleared up, and then I might need to do deltoid ligament reconstruction.
Yes, I agree, Dr. Ahmed. We need to lengthen the fibula because shortening of the fibula will lead to persistent valgus of the talus, regardless what you do with the deltoid ligament. And this is a very important message in this case. So the patient underwent another surgery. The next surgeon felt that lengthening of the fibula is difficult, and That's how we monitor the shortening of the fibula, as we can see here. The angle between the tibial plafond, the perpendicular to the tibial plafond and the intermalleolar line should be about 77. Here it is nearly vertical, so the fibula is clearly short. So the next surgeon feel it would be difficult to lengthen the fibula, so he did debridement of the syndesmosis and bony fusion of the syndesmosis. He wanted to achieve bony fusion of the syndesmosis, and he repaired the deltoid ligament, and he kept the fibula short as it is. Can you comment on this X-ray, Dr. Ahmed, Dr. Amr, Dr. Ossama? What's your opinion here?
Dr. Mokhtar, I think that without regaining the length of the fibula, here we have the lateral malleus is at the same level of the medial malleus.
Yes.
And so the repair of the deltoid was done in a redundant position. That's why he couldn't achieve stability to the ankle. So even after repairing the deltoid, there is still valgus in the talus and talar tilt, because we don't have a lateral strut for the talus, and the deltoid at the same time is fixed or is repaired in a redundant position. So this can never
Yes.
achieve stability to the ankle joint.
Yes, great. I agree with you, Amr. Without maintaining the length, the deltoid will eventually fail. And this is a stress view of the patient later on. So the deltoid ligament failed because the fibula is still short. So now we have to face. Then the patient came to me at this stage. I have to face and lengthen the fibula. This is the classic way the fibula is lengthened. Yes. To do an osteotomy in the fibula, and then the extraction until you reach the level you want. The problem here is that the previous surgeon did bony fusion of the syndesmosis, and I was not sure if I would be able to lengthen the fibula while the syndesmosis has some parts of bony fusion. So I did another idea for lengthening. I did a scarf osteotomy of the fibula. Okay, so we leave the bony fusion at the syndesmosis alone, and then we can lengthen the fibula until we reach the length we need. Of course, we need to clear the medial space first. And then you can see in the post-operative X-ray, the fibula was lengthened, and you can see the difference in the talocrural angle compared to the pre-operative image. You can see it was nearly vertical. Now it's in the normal range, and I always compare the angles to the opposite side, because it's not the same in every patient. And this is the patient later on after union, and he has good range of motion. Now, is it worthy? We are talking about mismanaged ankle fracture. Is it worthy to reconstruct the mismanaged ankle? I think yes. There is a key paper in the literature about treating malunited ankle fractures. The interval between the injury and reconstruction was from 1 to 107 months. The minimum follow-up was 10 years, so very long follow-up. They found 85% good to excellent results. So I agree with Dr. Ossama in his case that even if the patient has some arthritic changes in the X-rays, it worth revision, and revision can make these ankle stays functional for a longer time. They found that long duration between injury and reconstruction was not a contraindication, but was associated with a less favorable outcome and also preoperative arthritic changes. Ossama, Dr. Amr, Dr. Kholeif, in your experience, what is the most part of the ankle joint that is associated with malpractice? Is it the
For
fibula?
me, I think syndesmosis, but after awareness and lots of awareness about syndesmosis, it's okay. And second is fibular length. So I think fibular length and syndesmosis should be always checked by the surgeon during surgery.
Yes, because we say, as
I
Dr.
agree
Amr
with
said,
you,
that the best. Dr. Ahmed, do you have a comment?
Yes, I agree with Dr. Ossama. Syndesmotic reduction, because in many times we just rely on the anthropocean view of the syndesmosis, and we are not sure that the fibula is lying in the proper way in the incisura. It might be anterior, posterior, subluxed, or even has a rotation. And of course, fibular length is now getting much more concerned because, especially with comminuted fractures. So I think if we concentrate on these two items, lots of of fractures which has not been treated properly would be manages the problem.
Yes. In this paper, they made a comprehensive review of the cause of reoperation, and they found that the most common two causes were the syndesmosis and the fibula. These are the most common causes. And in our experience in Ain Shams University, we found the same. We did a study about these cases, and more than 2/3 of the cases were associated with fibula or syndesmotic malreduction. The important thing here is to remind all surgeons to be careful during repairing the syndesmosis. So I'd like to ask my dear friends about their tricks to avoid syndesmotic malreduction.
I think the method of reduction is important, how to do it. But using clamps may have the risk of malreduction when you put the clamp in a wrong position. If you put it in the posterior border of fibula, it will push the fibula anteriorly and vice versa. So you have to put your clamps during reduction correctly. Second, I think we have to be able to see the reduction of the fibula inside the incisura visually with the eye, better than doing it with the X-ray. So visual reduction is essential in such cases. So if we could see it, if we could reduce it properly, I think we would not get the problem of malreduction.
Yes, I agree, Dr.
I-
Ossama, that in cases like the case Dr. Amr presented with clear dislocation of the syndesmosis, you have to see the incisura, you have to clear the space and put the fibula in the incisura under vision. It's not good to rely on the clamp and on the X-ray in these cases because there is high degree of malreduction. What was significant also in our study in Ain Shams University about malreduced ankle fractures is that patients with significant syndesmotic malreduction were lower in their preoperative functional scores, and they were the most who achieved improvement in their functional scores after reoperation. So they were bad in the beginning, and they were the most who increased their scores in the functional scores after the operation. So I think the syndesmosis should be very cautiously managed in the primary stage. What about fibular length? Are there any tricks you have to avoid fibular length mismanagement?
I think, Dr. Mokhtar, I think I have to take very good intraoperative imaging to be sure that there is no fibular shortening. This is very common in comminuted fractures of the fibula, but in normal supination, external rotation, I think if you put the fibula back to its place, good reduction, this means that there is no shortening. But if we have comminuted fractures of the fibula, we need to restore the length, and this is through very good imaging to be sure that the dime sign or the sign of reduction of the fibula to its original length is okay at the end of the fixation.
I think
Yes,
we are
I
about to
agree.
finish our time now.
Yes, and the next thing is to compare to always to the other side.
Yeah.
So yes, the comparison to the other side is very important. So it's very important. Ankle fractures are not always simple. Early perfect management is important. Mismanagement is common laterally, and it's always worthy revising mismanaged ankle fractures to preserve the ankle, especially in young active adults. Again, I'd like to thank my dear friends from Cairo. To all who helped me in achieving this session. And I'd like to thank Dr. Parekh for his support. Thank you very much.